Hello, everyone, and welcome to this second edition in our new webinar series, Navigating Brain Health and Dementia. I'm Dr. Sandra Fryhofer, a Media Past Board Chair of the American Medical Association, and I'll be your host for today's session. This series is brought to you by the American Medical Association in collaboration with the CDC and the Alzheimer's Association. Our first webinar was about screening and diagnosing dementia and featured Dr. Rachel Whitmer and Dr. Barack Gaster. And if you missed it, you can still watch and listen by using the link in the chat. Our session today focuses on risk reduction for Alzheimer's and related dementias. There's growing evidence Alzheimer's disease actually begins more than 20 years before the onset of symptoms. And there may be things you can do now to reduce risk of developing it. Nearly 37% of Alzheimer's cases are associated with one or more of 8 modifiable risk factors. These include smoking, excessive alcohol use, obesity, hypertension, diabetes, lack of physical activity, depression, and hearing loss. Addressing these modifiable risk factors in midlife could prevent or delay up to 40% of dementia cases. Today, we'll be covering 2 issues: the link between vascular risk factors and developing dementia, as well as interventions and strategies for managing both hypertension and diabetes. And we're joined today by 2 great panelists, Dr. Cynthia Carlsson and Dr. Kate Kirley. Both are experts in chronic disease and other modifiable risk factors for dementia. Here's the plan. Each of our panelists will give a short presentation, then we'll move on to questions from our audience. Many of you already submitted questions when you registered, but if you didn't submit a question early, no worries. You can still add your questions to the chat. We'll try to get to as many of them as we can. Okay, let's get started. We'll begin with the link between vascular risk factors and development of dementia. Our first presenter is Dr. Cynthia Carlsson. Dr. Carlsson is Professor of Medicine and Geriatrics at the University of Wisconsin School of Medicine and Public Health. She's also director of the Wisconsin Alzheimer's Institute. Dr. Carlsson sees patients with memory loss at the Madison VA Hospital. Her research focuses on early detection and prevention of Alzheimer's disease. She's published over 160 research papers and has grant support from the NIH, the Department of Veteran Affairs, and the University of Wisconsin. Dr. Carlsson's also been involved on the national level with initiatives to improve dementia research, clinical care, and services for older adults. She was honored to serve as chair of the U.S. Health and Human Services Advisory Council on Alzheimer's Research, Care, and Services. Please welcome Dr. Cynthia Carlsson.
Thank you, Dr. Fryhofer. It's really an honor to be here today with you. Again, as she mentioned, I am a internist and geriatrician, and am really excited about some of the advances in not only treating dementia due to Alzheimer's, but also better understanding how different causes of dementia interact and finding ways to prevent and effectively treat these dementias. So today, we'll be talking about these associations between vascular risk factors and Alzheimer's dementia. Next slide. So here are my disclosures, as mentioned, the research studies that I participate in. Next slide. So today, what we'll focus on is talking about the interaction of vascular disease and Alzheimer's pathology, and then, more importantly, how we can use effective therapies to target the vascular risk factors and to understand where we are with the studies that show whether these will really truly prevent or delay progression of cognitive decline. And then touch base on how can we, as physicians, clinicians, and other areas, think about counseling our patients, helping them focus in on the most impactful risk factors for dementia. Next slide. So I think we're all aware about the aging demographics in the United States, and because age is the #1 risk factor for dementia due to Alzheimer's disease, you can see here that the number of persons who are living with dementia due to Alzheimer's is expected to increase in the coming decades fourfold. So again, you can see in where we are now about, in 2024, that there's, again, over 6 million people who are living with dementia to Alzheimer's, and that's not even including other types of dementia. And you can see that most people who have dementia are in the older age group. So again, as our population ages, we'll have more patients living with dementia unless we find effective preventive therapies. Next slide. And we know that these differences are also seen across different racial and ethnic groups. So for example, if you look at this graph, if I have a patient coming into my clinic who's in their mid-60s, who's African American, the chance of their having a dementia due to Alzheimer's is fairly low. Whereas if I have an African American or Latino, Hispanic, older adult who's in their 80s coming into my clinic, the chance of their having some Alzheimer's dementia is about 50%. So again, these differences with age and differences among cohorts make it more important that we study factors that are not just Alzheimer's related risk factors, but also vascular risk factors and other social determinants of health that may differ across communities. So this is a new and growing area of research. Next slide. And commonly our patients, and sometimes we as clinicians, will have some confusion about how dementia differs from Alzheimer's disease. So there's a common question in my clinic or in talks that I give. So again, dementia we know is the clinical syndrome when somebody has cognitive impairment in several thinking areas or domains that impacts their day-to-day function from what their baseline function was. And again, these are in the context of not being in the hospital or having a delirium or being acutely ill, but in someone who's in a more stable medical and psychiatric state. But we know that dementia can be caused by a lot of different pathologies. So Alzheimer's is the most common type, as you can see in this pie graph, but there's also Lewy body dementia, vascular dementia, frontotemporal dementia, dementia due to Parkinson's disease, and then a new form that we're actually just starting to define. We have a paper coming out in the next few months to help define it, that's focusing on a type of protein called TDP-43. So the easier acronym to remember is LATE, because the term is limbic predominant age-related TDP-43 encephalopathy. So you can see why we're using the acronym LATE instead. But again, if we look at the pie graph, you can see that Alzheimer's alone or Alzheimer's in combination with some of these pathologies is the most common type of dementia. And so you can see in the lower right-hand corner, the picture of the neurons and the extracellular space, that Alzheimer's is characterized by buildup of amyloid plaques, specifically beta amyloid 42, that builds up in plaques in extracellular space. And that leads to interneuronal damage with tau accumulation. And so again, the Alzheimer's disease is chiefly characterized by amyloid plaques and tau tangles. Next slide. And so when we think about how vascular pathology interacts with this, this study demonstrated by Rush, group at Rush, shows how vascular disease in increasing amounts increases the risk, not just for vascular dementia, but for Alzheimer's dementia, so the Alzheimer's pathology. So what this figure shows is if you look at the lowest bar, the lowest line that says the person has, this is based on pathology samples. If somebody does not have an infarct or vessel pathology, you can see what their risk factor was, what their probability was of having a dementia over the course of their lifespan. But as you increase to have gross infarcts and then gross infarcts and microinfarcts, so again, moving from large vessel disease down to small vessel disease, you can see as the lines increase, we get up to the aqua line at the top, that all these vascular pathologies increase risk of dementia due to Alzheimer's disease. So again, why is that? Next slide. There's numerous ways that vascular disease contributes to Alzheimer's dementia. So again, there can be low blood flow through the brain, through the intracranial atherosclerosis, increased arterial stiffness. You can also have cerebral amyloid angiopathy, which is characterized in Alzheimer's disease, where the amyloid builds up in the vessels and leads to microbleeds and other changes. You can also have changes in neurovascular unit, which we think impacts beta amyloid accumulation. Again, cerebral hypoperfusion or low blood flow to the brain, microinfarcts, And then there's some evidence, again, that there may be some impaired clearance of this toxic protein that accumulates in Alzheimer's disease, a beta amyloid. So again, there's a variety of pathologies, and these are all under active investigation because, again, what we hope to do is to be able to take what we learn about how vascular disease contributes to Alzheimer's and then turn it into ideas for therapies and prevention. Next slide. So this is an example from our team at University of Wisconsin by Dr. Leonardo Rivera. And what this study shows, if you look on the left, the gray bar graph, each of those clumps of bar graphs are different areas in the blood vessels of the brain. And these represent mean blood flow. And these are participants who had either Alzheimer's dementia, who are in the black bars, mild cognitive impairment, so cognitive impairment without associated functional impairment, or persons who are older controls or middle-aged. And what we saw in this cross-sectional analysis was that persons living with Alzheimer's disease had lower blood flow across all these different brain regions when using this specialized four-dimensional flow measure in the brain done on an MRI. So again, it gets a three-dimensional picture, but also the time of the blood flow going through the sections of the brain. And then you can compare that to the picture in the center, which is an amyloid PET scan. So again, PET scans are injecting a certain tracer that can stick to the amyloid in the brain. And then you can overlay that with the brain blood flow. So again, seeing that there's more association with amyloid pathology and poorer blood flow in those parts of the brain. Next slide. So again, what made me excited about studying this area is because I like to do things for my patients. I like to do studies where we do an intervention, and I am passionate about vascular prevention. So again, there's been a lot of studies that have supported that hypercholesterolemia, hypertension, obesity, diabetes mellitus, and physical inactivity, in addition to the other risk factors that Dr. Fryhofer mentioned, such as depression, hearing loss, that all of these factors in midlife contribute to Alzheimer's disease, dementia later in life. Next slide. The other risk factor, which may not be a true risk factor, but we know, especially those who are internists, family medicine physicians, and others who see patients in clinic all the time. You know, my memory clinic, we see veterans all the time who have obstructive sleep apnea. And we know that obstructive sleep apnea contributes to all these factors we're talking about, to hypertension, coronary disease, congestive heart failure, stroke. And you can see in this figure that those factors, again, feed into cognitive dysfunction. So again, in addition to the vascular risk factors, thinking about sleep apnea and other things that trigger these vascular risk factors. Next slide. When we add up the cardiovascular risk factors, we know that more leads to more, greater number of vascular risk factors increases our risk of dementia later on in life. So this study, I think you mentioned Dr. Whitmer talking to the group previously. Again, this study showed that persons who had one cardiovascular risk factor versus 2 versus 3 versus 4 in the green bar, that the more vascular risk factors you had, the higher your hazard ratio of developing dementia later on in life. So again, this suggests that there are a lot of targets we can use for prevention therapies. Next slide. And so in the Lancet had a commission that identified, again, many of the similar risk factors that Dr. Fryhofer mentioned. And so again, trying to treat diabetes, hypertension, head injury, smoking, obesity, exercise, that if we address these vascular risk factors and the other related modifiable risk factors, it could lead to a reduction of 40% of dementias worldwide. So again, there's a great target for us as physicians and healthcare providers to reduce risk of dementia. Next slide. And so what we know also is that if you combine somebody having risk factors for dementia due to Alzheimer's, such as with elevated amyloid on amyloid scans or on spinal fluid tests or now on blood tests, if you combine that risk factor with vascular risk factors, that seems to accelerate the risk of decline at an even greater extent. So these are data from the Wisconsin Registry for Alzheimer's Prevention, which is a cohort of over 1,500 adults who start in the study in middle age, cognitively unimpaired. But what you see in this graph is that if you have somebody who has the AB stands for beta amyloid, If they have beta amyloid, either positive or negative, and then you combine it with a risk factor for hypertension, such as hypertension or obesity, that those who have both the beta amyloid risk and the vascular risk that's identified have a steeper decline in their cognitive function compared to those without the risks. So again, people who have the green bar, the green line, are those who have both Alzheimer's pathology risk and the vascular risk. So again, even if somebody has Alzheimer's pathology, we can make a difference in the rate of their cognitive decline by addressing these vascular risk factors. Next slide. There are numerous studies that are underway now. There are some that have been completed that look at multimodal interventions. So the first was a Finnish geriatric study called the FINGER study to prevent cognitive impairment. It was a 2-year study in older adults based in Finland. And they did some diet interventions, exercise, cognitive training, and intensive vascular risk modification. And they showed improved cognitive performance in this 2-year study. And so what this has led to is a worldwide initiative, because we know that each culture exercises differently, eats differently. So now they call it the Worldwide Fingers Study, where they have studies going on in Asia, South America, Central America, and the United States to look at how we can use these multimodal interventions in different communities. And so the US Pointer study, sponsored by the Alzheimer's Association, is nearing completion, and again will help us better understand, if we do vascular risk monitoring, exercise, and these interventions, if we can help reduce the risk of dementia. Next slide. Another study done in California, the SMART study, so again, systematic multi-domain Alzheimer's risk reduction trial, again, is a smaller scale pilot study looking again at 2-year personalized risk reduction goals, health coaching, nurses visits. And across these, they did find improvements in cognitive scores and risk factor scores by addressing these vascular risk factors and other risk factors. So again, building evidence that there is some role for us as primary care providers, as internists, as other specialists related to vascular disease in preventing dementia. Next slide. We also are very interested in, can we repurpose the drugs that we already know are effective for cardiovascular disease to see if they help prevent dementia? Excuse me. There are a variety of studies ongoing to look and see, are there certain antihypertensive agents, therapies for diabetes mellitus, therapies for dyslipidemia. A lot of these have had some early promising data, but none quite yet shown to be effective, except for treatment of hypertension, which I'll talk about in the next slide. So the SPRINT MIND study was published several years ago, was part of the SPRINT study, as many of you are probably familiar with, and it had over 2,800 people who had a fairly average blood pressure of 130 millimeters per mercury. And they treated them for intensive blood pressure goals. So again, getting down to less than 120 systolic compared to 140 systolic, and looked at the risk of progression to dementia, mild cognitive impairment, or both combined. And they used a combination of several blood pressure medications, as noted here. And they did find that new cases of mild cognitive impairment were reduced, and the combined outcome of mild cognitive impairment and dementia. So again, dementia by itself was not reduced, but again, MCI and dementia was. And there are a lot of other studies, I won't have time to get into details, but a lot of other studies that do support that probable treatment of hypertension in midlife probably has a significant role in at least reducing the risk of developing dementia later on in life. Next slide. So what can we do to counsel our patients? So again, I know that they're going to be going through a lot of vascular risk factors and other risk factors for dementia. How can we help our patients be able to take control and feel like they have some ownership in controlling their risk for dementia? Again, I think that the strongest evidence is for hypertension management. So when I see patients in memory clinic who are maybe they end up not having memory problems, but or are worried about their risk of dementia, or when I see people in prevention studies, I commonly will emphasize if they want to pick one thing to focus on managing their blood pressure, which we'll be hearing about from Dr. Kirley in just a few minutes. So again, helping patients know their numbers, again, glucose control, cholesterol control, body weight, getting out and exercising, wearing their CPAP mask. But again, tailoring these therapies until we have stronger evidence about the individual types of therapies, specific medications, et cetera, to help reduce risk. But again, helping them especially to focus in on their blood pressure is what I do. Next slide. So in summary, again, vascular risk factors are pretty established now that they contribute in midlife to late onset or later stage Alzheimer's or dementia and later on in life. And so in many dementias have mixed pathology. So vascular management, I actually might help patients with Lewy body late pathology. Again, we don't know the full impact of these interactions, but we're learning more through research. And these multi-domain interventions seem to have good, promising results, but we know that they are resource intensive. We have to have teams to be able to do the coaching. So there are some studies ongoing that hopefully will give us more information about how to tailor this to our clinical practice. If I have to pick one thing, I think aggressive management of hypertension is going to be the best evidence to date to reduce risk for dementia. And then there's ongoing studies to look and see how specific vascular agents, or are there specific diabetes agents or blood pressure agents, cholesterol agents that have more effect. So those studies are underway. And then my last plug is always to get our patients involved in clinical trials. We'll never get any new therapies unless we all are part of these discoveries. So again, it's a great way for patients to partner with us to help bring them new therapies to their clinic. So I'll stop there. And I think we're moving on to Dr. Kirley.
Well, thank you, Dr. Carlsson, for sharing your expertise with us and for doing all this research. We're now going to shift our focus to interventions and strategies to manage both hypertension and diabetes. There's growing scientific evidence the same healthy behaviors that prevent diabetes, cancer, and heart disease may also reduce risk for subjective cognitive decline. This means patients and physicians can work together to decrease the risk of cognitive decline by addressing these risk factors. For this discussion, we turn to our second guest, Dr. Kate Kirley. Dr. Kirley is Director of Chronic Disease Prevention and Programs at IHO, the Improving Health Outcomes Group at AMA. In this role, she serves as AMA's clinical lead on chronic disease prevention initiatives. She's also at the forefront of AMA's efforts to advance chronic disease prevention by scaling effective QI solutions, advancing quality measurement and interoperability, and improving medical education. Prior to joining AMA, Dr. Kirley was a practicing family physician and health services researcher at North Shore University Health System in Chicago. She was also clinical assistant professor in the Department of Family Medicine at the University of Chicago. And until quite recently, she continued to practice family medicine at Northwestern's immediate care clinics. Dr. Kirley will now share more about ways to manage hypertension and diabetes and why it's so important. Please welcome Dr. Kate Kirley.
So much, Dr. Fryhofer and Dr. Carlsson. You really just teed me up so nicely. If we go on to the next slide, I'm going to spend the bulk of my brief time really talking about how we can deliver better hypertension care, which we've heard is perhaps one of the best things that we can do to prevent dementia. So if we go on to the next slide, let's think for a moment about how we're actually doing as a country when it comes to delivering high quality blood pressure care. If we look at blood pressure control rates across the country and over the past 20 years, what we are unfortunately seeing is that for about the past 10 years now, our blood pressure control rates have been in decline. So this really speaks to the urgent need to do more focusing and put more resources towards improving our blood pressure care. So if we go on to the next slide and we think about how can we deliver high quality hypertension care, when we look at the literature and actually through our own experience at AMA working with dozens of healthcare organizations, it's very clear that there are some common gaps in hypertension care. And I think these really conveniently arrange themselves into three neat buckets. So the first bucket is the issue of inaccurate blood pressure measurement. We know that many organizations do not necessarily use a blood pressure measurement protocol. We all tend to deploy slightly different techniques when we measure blood pressure. This is both within our clinics, as well as when our patients measure their blood pressures at home. And this variation really contributes to inaccuracies in blood pressure measurement. And that makes it tough for us to really diagnose hypertension accurately and also to assess the effectiveness of our treatment well. The next area that is a common gap in care is treatment inertia. This is really actually the biggest gap in care when we look at hypertension management. Treatment inertia is this situation where we fail to either initiate treatment or intensify treatment when it's indicated for our patients. And we know that most of our patients with uncontrolled hypertension are being suboptimally treated. The last bucket that is a gap in care, I really think of as patient engagement issues. So we know that many of our patients struggle to adhere to their treatments. About half of our patients with hypertension don't take their medications as prescribed. We also know that we tend to not follow up with our patients as frequently as would be ideal to achieve blood pressure control quickly. So these are what we know to be very common gaps in hypertension care. And if we go on to the next slide, let's start talking about solutions. When we think about improving blood pressure care, and really any type of chronic disease care, I would pose that the MAP framework is a helpful way to organize your thinking. MAP, it's an acronym. Each letter stands for something. M is about measuring accurately, really making sure we obtain accurate and actionable blood pressure measurements to both diagnose hypertension and to better assess blood pressure control. A is acting rapidly. This is making sure that we initiate and intensify treatment urgently for our patients when it's indicated. And then P is really about partnering with our patients, really supporting our patients in self-managing their condition. So if you go on to the next slide, I want to talk a little bit more specifically about how you can put this into practice in a really pragmatic way. So to start by breaking down measuring accurately, one thing we can do in our clinics is make sure that we are using automated, validated upper arm devices. You might wonder about that automated part, but really automated devices help us really eliminate a lot of user error in blood pressure measurement. Validation is also very important, and we do want to use those upper arm devices. Wrist devices are really only for patients who may have a specific issue with an upper arm device. Next, we want to make sure that we are using proper preparation and positioning of our patients and proper measurement technique. This means making sure that whoever on our care team is measuring blood pressure is trained and retrained and competencied on a regular basis. Blood pressure measurement is actually a challenging skill. It's a skill that decays quickly over time, so we need to keep retraining on this. We want to make sure that we implement a standardized blood pressure measurement protocol that is very clear about all the steps that we want to follow when we measure blood pressure, so it happens the same way every time. And if we have initial high blood pressure measurements, we want to be taking confirmatory measurements. So these are all very concrete action steps we can take to improve our accurate measurement. And then if we move on to the next slide, let's talk about how we can act rapidly. First of all, using an evidence-based treatment protocol is very, very helpful. The organizations that do best with blood pressure control use treatment protocols. And of course, it's never a replacement for a clinician's clinical judgment, but it really helps us all get on the same page. It makes decision-making a bit easier, and it's a playbook that the whole care team can use to really understand what's going to happen next with the patient with high blood pressure. We really encourage the use of single pill combination medications. So these are medications that have more than one class of medication combined into a single pill. These are very helpful because we know that most of our patients with uncontrolled hypertension require 2 or more medication classes to get their blood pressure under control. So let's put it into a single pill to make it easier for them to adhere to their treatment. And then we want to make sure that we are following up frequently with patients until their blood pressure control is achieved. Once we make a medication change or initiate a medication, we can see them back as soon as 2 weeks later, maximum 4 weeks later, to assess how they're doing and adjust treatment if necessary. And now let's move on to partnering with patients if you go on to the next slide. Some key strategies to put in place with partnering with patients is to systematically assess and address medication adherence and really problem solve with our patients about solutions there. Whenever we're communicating with our patients to partner with them well, we want to use collaborative, non-judgmental communications. We want to connect our patients to proven lifestyle interventions, And another strategy that we can use is incorporating self-measured blood pressure, or SMBP, into our practice. And let's talk about that a little bit more. So if we go on to the next slide, self-measured blood pressure, or SMBP, is exactly what it sounds like. It's when a patient takes their blood pressure measurement outside of the clinical setting, usually at home. If you go on to the next slide, this is recommended by our clinical guidelines. For example, this is recommended by the current ACC and AHA hypertension guideline. It allows us to more effectively confirm a hypertension diagnosis. So it helps us weed out things like white coat hypertension, or figure out if a patient has masked hypertension or truly has essential hypertension. It also helps us titrate our medications, and it is a recommended strategy to improve blood pressure after a patient initiates medication. It's very important to still use it with other strategies like physician-led team-based care, telehealth. In other words, we don't want patients going off and taking measurements at home and then never finding out what those measurements are. We want to get those measurements back so we can use them to make treatment decisions with our patients. It can also help improve medication adherence, and really it helps our patients better self-manage their condition. So if you go on to the next slide, it is important to do self-measured blood pressure in an evidence-based way. I see lots of physicians who sort of have patients measure every day. Really, the evidence-based protocol is to measure twice in the morning, spaced a minute apart, twice in the evening, spaced a minute apart, and to do this for a week and use that week's worth of blood pressure measurements for clinical decision-making. Now, many patients are going to struggle with doing this that frequently for a week. If you can get 3 days of measurements, that is helpful for clinical decision-making. And then if you go on to the next slide, things that we want to do when we use SMBP with our patients. We want to make sure that they use a validated home blood pressure device. I'll share a resource in just a moment so you can see how you find those. You want to make sure that your patient has a cuff size that fits them properly. We always need to train our patients on how to measure their blood pressure properly. Just like our care teams and we need training on proper technique, our patients also need that training. We want to make sure our patients know how to get the results back to us, again, so that we can use them with our patients for clinical decision-making. And then when we do receive those blood pressures back, we want to average them. So we calculate an average systolic and an average diastolic, and we use that for our clinical decision-making. So if you go on to the next slide, I'm going to quickly share a number of hypertension resources. I will tell you that we have QR codes on these next few slides, so you may want to whip out your phone right now so you can grab some of these resources. So if you go on to the next slide, first of all, if your practice or your organization would like more support in hypertension-related quality improvement, we offer our AMA MAP Hypertension QI program. This is something that we offer for free to practices of all shapes and sizes. So it is more about some of the steps that I talked about, customized coaching, metrics as well. So feel free to contact us if you are interested in receiving that support. If you go on to the next slide, a couple times I have mentioned that it is important to use a validated device, both in the office and if our patients are measuring at home. The US blood pressure validated device listing is a place where you can help your patients find those devices. If we go on to the next slide, education in blood pressure measurement is super important. On our Ed Hub, we offer free educational modules that really are a simulation type of experience to help you or anyone on the care team make sure you have good skills with blood pressure measurement. And then if you move on to the next slide, if you really want to implement really good self-measured blood pressure into your practice, I recommend checking out the SMBP Jumpstart curriculum, also freely available on the Ed Hub. This helps healthcare organizations really learn about SMBP and really plan and implement an evidence-based SMBP program. Okay, we're going to change gears for a couple of minutes and talk briefly about better diabetes care if we move on to the next slide. And I'm really going to use the same type of framework that I just used for hypertension. So if we go to the next slide, thinking about common gaps in diabetes care, very similar to hypertension. We know that we tend to have inadequate screening and monitoring. The rates of screening and diagnosis of diabetes are suboptimal, as are our frequency of monitoring for complications and comorbidities. We also know that we have treatment inertia with diabetes. First-line treatments for diabetes are frequently underutilized. And we also know that we tend to not support our patients with self-management of their condition as well as we perhaps could. we know that diabetes self-management education services, or DSMT, is really an underutilized service. So if you go on to the next slide, let's talk about those M, A, and P action steps for diabetes. When we think about measuring accurately for diabetes, we want to make sure we're implementing guideline-directed screening, really identifying patients who have previously undiagnosed diabetes as well as prediabetes. And we want to have protocols in place for regular monitoring of glycemia, as well as for those comorbidities and complications. If you go on to the next slide, when we think about acting rapidly for diabetes, we want to make sure we also use evidence-based treatment protocols here. And we also want to make sure we're following up frequently with our patients until glycemic control is achieved for them. And then if we go on to the next slide, when we think about partnering with our patients, much like hypertension, we want to assess for and address treatment non-adherence. We again want to collaborate, or we want to communicate in a collaborative way with our patients. And from a self-management standpoint with diabetes, really try to connect our patients with those diabetes self-management education services, really get our patients to see those diabetes educators. If you go on to the next slide, couple of resources for you to improve your diabetes care. In this case, I want to point you towards AMA Steps Forward. Not too long ago, we launched a new toolkit for managing type 2 diabetes. Many wonderful ideas in there for how to approach diabetes quality improvement. And if you go on to the next slide, again, one more QR code there. That QR code will take you to that toolkit. But I just want to briefly mention that the AMA offers a whole host of resources, both for diabetes management, but also for diabetes prevention. So if diabetes prevention is something that you are interested in, I encourage you to visit amapreventdiabetes.org. And I think with that whirlwind, that wraps up my portion of the presentation. And back to you, Dr. Fryhofer.
Well, thank you, Dr. Kirley, for your leadership in this space and your insights. And next, we'll move on to our Q&A portion. So we now have time for questions from you, our audience. Many of you submitted questions when you registered, so we'll start with those, but you can still submit your questions online in the chat, and we'll try to get to those as well. And if we can't get to them today, we'll try our best to address them during future webinars. Our first question is for you, Dr. Kirley. It says, if I'm already addressing multiple chronic disease issues and risk factors with patients, like, for example, a family history of Alzheimer's and a personal history of concussions, hypertension, and long-term use of blood thinners, what's the best way to also incorporate a discussion about Alzheimer's risk reduction, particularly given the time constraints most physicians face?
Yeah, fantastic question. I think I certainly come at it from a primary care viewpoint, and thinking about the time pressure aspect. One of the nice things about primary care and really chronic disease care is that we get multiple bites at the apple with our patients, right? We get to see them again and again, and we're not going to fix any of these things overnight. We're going to be working with our patients over time. I also think that the person who asked this question is already doing so much to address risk factors for Alzheimer's disease and dementia, really should be congratulated. So they're already very much on the right track. So I think it is focusing on how you double down on those areas, how you really optimize your hypertension care, how you really optimize your diabetes care. And you can use this fact about hypertension and diabetes being a risk factor for Alzheimer's disease in your shared decision-making with your patients, right? So if that is an important issue to them to prevent dementia, to prevent Alzheimer's disease, that is another motivating factor to improve their blood pressure control and their diabetes control.
That's a very good point. Dr. Carlsson, please take this next question. Can you discuss pros and cons of blood tests like amyloid, tau, and ApoE4? What are your thoughts about characterizing people with 2 copies of the ApoE gene as having a genetic disease?
It's a great question. So previously, really for the last 10, 15 years, we've been able to look at amyloid buildup in the brain using these PET scans. But again, they're expensive. They're only limited to certain regions. And then over time, we're able to look at spinal fluid tests. So again, I've done thousands of lumbar punctures to look at spinal fluid levels of beta amyloid. But again, not everyone obviously wants a lumbar puncture. And so, unfortunately, the blood tests really lagged behind for a long time and weren't really able to tell us much about brain health. Well, that has all changed in the last 5 years. I hope my bandwidth is holding up here. So again, the last 5 years, we're really able to better characterize brain health with amyloid and tau levels using blood tests, so that the blood tests are almost as good as the PET scans. So what that means is that in the future, primary care physicians, other clinicians out in diverse communities throughout our states will be able to have access to these blood tests to help characterize if someone's at higher risk for having Alzheimer's pathology or not. So again, but what we do with that information is always really important. So if we use this test to help someone with shared decision making, or to be able to understand what their risk is for progression down the road, that can be helpful. Now there's some newer therapies that actually focus on amyloid, called lecanemab is the only one that's currently approved now. The aducanumab was approved, lecanemab is now approved. But again, it's if somebody has amyloid, then they might be eligible for these therapies. So because dementia is caused by numerous factors, these blood tests and biomarkers are going to become more and more important for general practitioners in the future too, because we're going to be asked to kind of help decide if somebody's right for a certain type of therapy. But right now, so that's the pro, is that we are moving these, biomarkers into primary care. The cons are that a lot of us who are, those of us in primary care, like, what do we do with these now? How do we get people these therapies? And so because lecanemab's not widely available and aducanumab was available, but now it's not going to be available. So there's, it's a rapidly evolving field. And so I think that's the cons, is that these biomarkers are advancing, but we need to better understand how can we best use them in primary care to be aids and not just other kind of factors that are adding to the confusion. For ApoE genotype, so again, ApoE genotype, if somebody has one copy of the ApoE4 allele, their risk is maybe about 3 to 5-fold increased risk of getting Alzheimer's. If they have 2 copies, the risk may be 10-fold. But again, there's these other, it's a relative risk increase. So if somebody's 65 and really good vascular health, their baseline risk may be low. Whereas if someone's 85 and has poorly controlled hypertension and family history, so there's different factors that are going to weigh into how dangerous that genetic risk is. So we're learning more and more about what ApoE4 allele means and doesn't mean. But if you look at people with Alzheimer's dementia, about half of people don't have ApoE4 allele. So having it doesn't mean you will get dementia due to Alzheimer's, and not having it doesn't mean you won't get dementia due to Alzheimer's. So there's still a lot we need to learn about it. But right now in clinical practice, I don't use blood-based biomarkers in my clinic or ApoE testing unless we use them in research context all the time, and they will be moving into clinic soon. But we still have a lot of clarification about what their role is.
So if a patient asks us about them, no, we don't have a blood test now, but the research we've heard about today might give us one later. And just because someone has the 2 ApoE genes, it doesn't mean they're definitely going to get Alzheimer's. Right. We still have to look at those modifiable risk factors. Is that what you're trying to say? Or okay, well, thanks. That's a question I think a lot of us get asked a lot about. Mm-hmm. Dr. Kirley, let's go back to you. Some of the modifiable risk factors are associated with structural and systemic inequities in our healthcare system and in our country more broadly. Are there ways to address or acknowledge this in our medical practices?
Well, this could be a whole several hours of presentation and discussion in itself. I think it's a great question. So absolutely, we definitely know that certainly with hypertension, with diabetes, there are significant structural systemic inequities. There are inequities in access to care and outcomes for these conditions for sure. And I also think as physicians, a lot of times many of us find this topic overwhelming, and we want to figure out a way to help here, but we also don't know how to do this within the scope of sort of how we were trained. So I think for many, a place to start is to examine potential inequities in your practice and within your community. And that starts with looking at your data if you're able to. So are you able to look at your hypertension measures, your diabetes measures, look at them broken down by subpopulations defined by race, ethnicity, gender, different groups of people. If you don't have good enough data to do that, think about how you can get good enough data to do that, because I think starting to look at the scope of the problem in your practice is a very good place to start. But also talking with our patients, understanding the challenges that they're facing, the different social drivers that they experience, and how the determinants in their area influence this. Talking to communities on better understanding the community in which you practice, and understanding what the social and structural context is there. And I think once we start to understand that, oftentimes we find places where we can start to work and make changes.
Well, thank you for that. And as many of you watching know, the American Medical Association has a Center for Health Equity. So this is a big concern to us here at the AMA and to all physicians throughout the country. Dr. Carlsson, I've got another question for you. Studies have shown a correlation between hearing loss and development and progression of Alzheimer's disease. Is there any evidence that hearing aids can help reduce that risk? And what about lifestyle interventions to lose weight and lower blood pressure and cholesterol? Do they reduce risk of developing Alzheimer's?
Great question. So again, with the hearing loss, there have been studies over time, and initially there was some thought about common pathways that contribute to hearing loss and to cognitive impairment, and some of those pathways were vascular. So whether there's a shared kind of risk for hearing loss and decline in brain health is one thought. But also, I think as we're learning more and more, and I was just talking with a patient this morning about this, that hearing is not just a matter of, do we hear a conversation so we can remember it later, but are we getting that sensory input that our brain depends on to, stimulate those neural pathways and keep our brain function intact? So again, with our vision, our hearing, all those sensory input that really helps our brain to maintain those neural pathways. And so I think we're recognizing it's not just a matter of, did my loved one hear me? Or is that why they can't, if they didn't hear me, they can't remember what I said? But there is building evidence that it actually may, by addressing hearing loss, that may help improve cognitive function. And there are some ongoing studies. That's a great question. There's some ongoing studies looking at, now that we can more widely have access to over-the-counter hearing aids, can we use those even in a primary care setting, or maybe patients can't afford the higher end ones? Can we use over-the-counter hearing aids to see if that makes a difference in cognitive function? So there's studies that are ongoing right now. Working within the VA system, again, my veterans have access to hearing aids, so that's part of our standard approach, is to make sure that they have access to good amplification tools. And again, with the other risk factors that were mentioned, losing weight, controlling blood pressure, cholesterol, whether they reduce the risk of developing dementia. Again, the best evidence is for controlling hypertension. As I mentioned with the Sprint Mind study, there have been some studies looking at people who already have dementia due to Alzheimer's, and whether therapies like statin drugs or DHA, like types of fish oils, help delay progression of the disease. But it looks like that these types of therapies probably are going to work better if you get them before someone develops symptoms of the dementia. So there have been some prevention studies looking at statin drugs, looking at some other fish oils, and some of those have shown some promise in mechanisms, but not necessarily effectiveness in delaying onset or progression. So there's still research being done, but again, I think the strongest evidence so far is for hypertension management, which is why Dr. Kirley's work is so important, to help us all help our patients to manage their hypertension.
Okay, I've got a question from the chat, and this is for Dr. Kirley. How can you manage the impact of medications for pulmonary disease and GERD on Alzheimer's, especially when you only have one especially when you have one if the late onset markers? Not sure exactly what that's asking. But the
and
impact
I'm wondering
of
if Dr. Carlsson has any thoughts either. I'm also trying to come up with a good answer for you. Maybe we
Can you read that
chew on
again?
that one.
Dr.
Yeah,
Fryhofer?
do you have
Okay.
one?
I'll read what I have again. How can you manage the impact of medications for pulmonary diseases and GERD on Alzheimer's? In
Okay.
there.
Yeah, pulmonary. Okay, so so I assume they're getting at the proton pump inhibitors and the impact that they have on cognition. Again, I as a geriatrician, I think a lot of us as family medicine internists, we try to take a whole patient approach and evaluate what is the relative risk of this medication on a person's cognition or other systems versus what it's helping provide. So again, I think it comes back to a lot of shared decision making with patients, whether it be pain medications, medications for anxiety, for all kinds of other conditions, bladder conditions, things that might have adverse cognitive effects. I'm always talking with patients and weighing the pros and cons. And sometimes it's a matter of just putting it out there that some of these therapies may have some negative cognitive effects. How important is that to you compared to how much it helps your reflux or pain or whatever the condition is being treated is? So it really comes back to shared decision making with the patient.
And some of these acid blocking medications are available over the counter, so patients may start taking them. And so that's why I think it's important, to ask what over the counter medications people are taking. And also, just because they were taking something when they needed it doesn't mean they have to continue to take it. That's I think that's an important point too.
The prescribing is very important. And then, the other thing we always watch for is Tylenol PM. So the PM and anything stands for basically Benadryl, diphenhydramine. So that's going to cause negative cognitive effects. So assessing over-the-counter medicines is really important.
Thank you for that. Dr. Carlsson, another question for you. How important are static risk factors like family history compared to the modifiable risk factors for dementia?
That's a great question. There were some twin studies done in the past to try to tease apart how much is basically genetic versus environment. And it looks like it's about 50-50. The genetic factors we know about, really ApoE4 allele is the biggest one that stands out for late onset Alzheimer's. Thankfully, the autosomal dominant forms of Alzheimer's dementia are very, very rare. Again, those are a small number of people who live with Alzheimer's have that autosomal dominant, one of those three risk factors. So again, the other risk factors for genetics we don't fully understand. There's still a lot of studies going on, but again, there's at least probably 50% is environmental. So a lot of those can be, risk factors. Some of them are going to be vascular risk factors. Some are other social determinants of health, stress, lack of access to good resources, and other things that cause disparities. And so there are a lot of areas I think we can work on systematically as a country, and also in our communities and in our clinical practices.
So, Dr. Kirley, I've got another question from you from the chat. If blood pressure averages remain lower than 135 systolic and 90 diastolic, is that considered uncontrolled?
Depends perhaps the source of our blood pressures that we're thinking of for the systolic. If we're talking about self-measured blood pressure measurements, 135 is equivalent to an office measurement of 140. So depending on what blood pressure threshold you use, there are two different measurements, whether we're talking about self-measured or in office. With a diastolic of 90, again, self-measured blood pressure, the diastolic is 85 is equivalent to 90. So some of the answer to that question depends on, are we talking about self-measured blood pressure averages, or are we talking about in-office blood pressure measurement averages? Some of this also depends on what threshold are you using. And what we saw and what Dr. Carlsson nicely outlined for us from SPRINT was that more aggressive management in SPRINT was associated with the outcome, decreased outcome of mild cognitive impairment and the combination of mild cognitive impairment and dementia, suggesting to us that we probably should be pushing a bit lower with our patients. So, we have ACC and AHA telling us to shoot for 130 over 80. And I think in this context of talking about dementia, that may be very, very reasonable for many of our patients.
Well, I think we have time for one more question. Which professionals do you think are important for primary care physicians to collaborate with in managing and reducing the risk of Alzheimer's disease and other related dementias? Who wants to take that? And just a quick answer.
Start from the hypertension side. I love seeing increased collaboration with clinical pharmacists who can really help us optimize our medication management, I think.
Well, unfortunately, we're out of time for today's session. Thank you, Dr. Carlsson and Dr. Kirley, for sharing your expertise and insights. And many thanks to all of you for joining us today and for your great questions. And if you want CME credit for today's discussion, here's what to do. Log into your free AMA EdHub account and click on the Take Quiz button. And if you don't already have an AMA EdHub account, please sign up. It's free. And then take the quiz and claim your CME credit. And as a reminder, this webinar was the second in our 3-part series, so there's more to come. Our next webinar will focus on treatment for Alzheimer's disease and related dementias. It's scheduled for Monday, July 1st at 12 p.m. Central, 1 p.m. Eastern. You don't want to miss it. You can find a link to register in the chat. And if you want to watch this webinar again, there's a link in the chat to do that too. Thanks again for joining us and have a great rest of your day. For the American Medical Association, I'm Dr. Sandra Fryhofer.